Well, everyone come in the room. Welcome. It's July 24th, 2020. I was going to say 2001. I'm so far behind. 19 years later. Um, Welcome to MECCA Moments this week. So happy to have our Dr. Mack here and Dr. Molock here. Dr. Molock, Dr. Mack, can you introduce Dr. Molock to our audience today?
Sure. Dr. Molock. Dr. Sherry Molock is an associate professor in the Department of Psychology at the George Washington University in Washington, D.C. Dr. Molock teaches undergraduate and doctoral courses in the fields of clinical psychology and conducts research on the prevention of suicide and HIV in African American adolescents and young adults. Dr. Molock's work has appeared in a number of professional journals, has served on a number of local and national boards, and currently serves on the editorial board of the American Journal of Community Psychology. She also serves as a grant reviewer for the NIMH, NIDA, CDC, and SAMHSA. She recently served as a member of the scientific work group that worked with the Congressional Black Caucus Emergency Task Force on Suicide Prevention in Black Youth. In addition to her work in psychology, Dr. Molock and her husband, Guy Molock, are the founding pastors of the beloved community church in Accokeek, Maryland, and their ministry focuses on family healing that is designed to bring spiritual, physical, and emotional healing to the community. She's a proud mother of the Molock Jewels, Amber, Jelani, and De'Ara, and a proud Mimi of Michaela and Aaliyah. And one last bit of information is that Dr. Molock also served on my dissertation committee at the George Washington University and was very instrumental in helping me to obtain my doctorate degree as a student at the George Washington University as well. So thank you, Dr. Molock, and welcome.
Thank you.
Welcome. That was some great information. It's cool to have someone who was instrumental in your career on here.
Exactly. And when we were, when we thought about this topic to present today, she was the first and only person that I thought about in speaking on this important topic today.
Well, thank you for inviting me and for having me.
Absolutely. Well, let's get right into it. I will say, I was talking earlier, if we're all at home, so if I disappear, I have a package coming today. So
we all have disclaimers. I have dogs, and so they may hear them barking if I get a package.
We all have deliveries.
Package day.
Yes. So today we're talking about suicide in the Black community. When we think about that, that's such a heavy topic, and oftentimes we hear, "Oh, well, we don't need to hear that because that doesn't happen with Black people." That's a myth. Dr. Molock, can you explain the myth around suicide in the Black community?
Yeah, I think a lot of times, unfortunately, because of the stigma associated not just with suicide, but with mental health or mental health challenges, that Black folks often think that that's something that white people do and that that's not something that I have to worry about or that people in my community have to worry about. But that's actually a myth. Suicide is the second leading cause of death for youth between ages 10 and 19. It's the third leading cause of death for Black youth in that same age group. And really alarmingly, suicide attempts rose 73% between 1991 and 2017 for Black adolescents. Ooh. And the rates rose 122% for adolescent Black males during that same time period. And we also know that unfortunately there was a precipitous increase in the suicides for Black children under the age of 12. And so for the first time, the suicides in that age group surpassed those for white. So we need to sound the alarm about this. This is not something that other communities do. We do this too.
Yeah, so clearly the data shows that this is not a myth. This is actual reality for especially Black adolescents in our community, correct?
Yes, definitely. I think sometimes it's hard for people to believe that children and adolescents are thinking of taking their life because we have the sense of you have your whole life ahead of you and what do you have to be sad about? And if you are having challenges or problems, these are temporary problems that will go away when you grow up. But we forget that for youth, it's kind of like if you have a romantic relationship and it doesn't go well, and your parents would say to you, there are plenty of fish in the pond or in the sea. And remember, this is the first time that young person has been fishing. So they don't know that there are a lot of more fish involved in the sea, right? This is their first experience with that. They also don't have the same coping strengths and what I call your coping repertoire, the flexibility that you can have in different kinds of coping skills. When you're a young person, you're just acquiring those coping skills. You may not necessarily have all the coping skills that you need to combat things like depression.
And that's absolutely true. And we're not going to even talk about the development of the brain. It's not even,
right.
Reach that at 25 or so.
Right.
And so
for males, right?
Right. And so you see this, you see all these things stacked up against, this particular population, and we still have like this myth, which looking at that data, talking about these kinds of things that are happening with this population, you would understand more clearly that this is a challenge. When you look at the warning signs, I mean, you talked about some of the things that may precipitate kind of these issues, but what are the warning signs that we should look for when we're dealing with our children or people in our family? What should we look for?
So there are a lot of warning signs that are associated with depression, because depression is a major risk factor for suicide along with anxiety. So you should look for things like the person's mood has changed, a significant change, and they're sad or lethargic for most of the days, for at least a 2-week period. There's something called anhedonia, which is a lack of interest in your normal activities. You might see young people withdrawing. Some young people, you might see them, they don't look sad, but they look angry or they're very irritable. And that's more common in adolescents than it is in adults. You might see young people withdrawing from friends, not really wanting to be bothered, not motivated to do things that they used to find fun to do. You might see a drop in grades or engaging in other kinds of extracurricular activities. Sometimes you might see kids give away important or precious items or things that they own because they've made a plan and they no longer plan to be here. So those are just some of the warning signs.
Now, if I can just add a little bit to that, with regard to the signs and the warning signs, and sometimes they may not even appear to be sad or in that moment because they've already made that decision. So there's a kind of euphoria because the decision is made, and they already know that they have decided on completing the suicide and that they will be out of this pain that they've been in. So and I think that sometimes when people say, they were happy, they didn't see it, there was nothing there, I just spoke to them and they sound really well, that was because they had already made up their mind that this is what they were going to do.
So that's an excellent point.
Mm-hmm.
So you have sadness, and then you see a sudden lifting of the sadness, and there's nothing in their circumstances that have changed to warrant them feeling much better. Things are still, the things that sometimes precipitate episodes are still present. Then that sometimes you should be actually concerned about that.
Yeah, absolutely.
It sounds like there was a resolution, a resolve in life. And so we hear all these signs. Should we be looking at the time frame? Is there over a period of time? Is it a certain window of time? Is there a certain expression of these behaviors? How long should you see these? Is it sudden? Can you delve into that?
So depression, unfortunately, tends to be an episodic and chronic condition. So it's not unusual for someone to have struggled with depression for several months. In fact, in adolescence, some people argue that it's from the beginning when you have no symptoms till you feel better and feel like yourself again can be as long as 6 months.
Yeah.
So a really long time, particularly in a young person's life. On the other hand, though, I think Dr. Mack's point is well taken. Don't assume because you don't see all those symptoms that something's not going on. Because the other thing that can happen, particularly with young people, is that sometimes young people make really impulsive decisions about taking their lives. And there might be an acute problem or a situation or stressor that's going on, and they will impulsively attempt to take their lives. And so that's why you will sometimes, there is some research that suggests, particularly amongst African Americans, sometimes you will see almost no signs before suicide attempt. And so it's really important to kind of keep the lines of communication open with your young people to make sure that you're really communicating with them, the one that you care about them, but also that you're tracking how their moods are going and how their situation is going.
Yeah.
I think you're making a very good point, and you said one word, which was assumption. And sometimes we can deal with those assumptions, frankly and simply, just by asking questions. And so, what are the questions that you can ask if you feel or you may have an intuition about something is changing about an individual that you care about? What should you do?
You need to be direct. I think one of the things that there's a myth out there that if you ask someone, are they thinking about suicide, that will make them make an attempt. That's actually not true. What you're doing is you're giving the person permission to talk about it. And you're basically saying to them, this is a safe space for you to talk to me about things that are concerning you. So you can ask people directly, are you thinking of harming yourself? Are you thinking of killing yourself? That's a direct statement. I don't like when you say things like, you're not thinking of killing yourself, are you? What you're basically telling the person is, I can't handle this, so don't say it. Mm-hmm. So you want to be direct, saying, I'm concerned about you. You don't seem to be yourself. You seem to be sad. You seem to be depressed. You can label what you see and then just ask, I'm concerned that you might be thinking of harming yourself. Or are you thinking about killing yourself? If the person says yes, you can ask them specifically, what were you planning to do? The reason why that's so important is that the more specific the plan and the more lethal the method, by that we mean what methods or mechanism was the person planning to use. So if someone wants to use a mechanism that's most likely very lethal, like a firearm, that's much more cause for alarm than if someone has a really vague plan and says, well, I don't have anything in particular I'm thinking about doing. I just don't want to be here anymore. That's a very vague plan. And the risk is not quite as high if someone says, I have a gun in my house, I know what the bullets are, my parents have a gun, and I know where it is, and when my parents go away for the weekend, I'm planning to do it then. That's an emergency. That's a very specific plan. The access to the means is readily available, and the method that they're planning to use is very lethal.
Yeah, and Dr. Molock also described, as she was making the comparison, one is actually suicidal, and the other has that suicidal ideation where it's just wanting to get rid of the pain, not really having a real plan, not really having access to anything, but they do have this ideation because it again will help them to get rid of that pain. So there's that difference. And when you're asking those specific questions, you know that this may be the ideation, but not necessarily someone who's actually going to follow through and complete.
Right, we call that suicide intent. So you're looking at thoughts, which is ideation, and then you have intent, which is, do you have a plan?
Yeah.
And the more detailed your intent is. Also looking at, is the person preoccupied with this? So is this like a fleeting thought, or this is something that the person thinks about all day, every day, and has been thinking about it for a while and thinking of different scenarios? And young people get on the internet, and unfortunately the internet has lots of information about this. So they're looking for the best way to do this, where the quote unquote best way to do this, where there's minimal amount of pain, for example. All of that is cause for alarm. The more specific people are, the more preoccupied they're with it. And the more lethal the method that's being chosen, the more you're concerned.
And it sounds like both are urgent, but there's a degree of urgency between the intent and actual having a plan, a concrete plan.
Yes.
And just listening to you, I'm trained, we're all trained, but for an untrained person who is listening to all these signs and symptoms, and it could be overwhelming. So
definitely.
What do you do? Do you call 911? Do you call the suicide prevention line at the bottom of the screen? What do you do when you notice these things are happening?
So first of all, let me say this. We're not asking, when you're asking you to be concerned, we're not asking you to be a diagnostician. You don't have to be a clinical psychologist with a PhD.
Right.
Believe it or not, what you really need to be is present and compassionate, and don't be judgmental. The judgment of, I can't believe you're thinking about that, and if you're from a faith community, that's a sin, don't you? That's condemnation, and that person probably has low self-esteem. They don't need your condemnation, and they don't need your judgment. They need a good listening ear. They need someone who's someone who can have empathy for what they're going through. You can, what we call, join them in the moment, so be present there with them. And also talk with them about getting help immediately. If it's an emergency situation, yes, you can call the 1-800 suicide hotline. There are crisis workers who are trained specifically to do the suicide risk assessment with you, go through it with the person on the phone. But if that person won't come to the phone, for example, they can still walk you through what you need to do to get that person to get help. So the Suicide 1-800 hotline, also your local crisis center, if you know that number. If you don't know the number, it's okay, because the suicide hotline will link you to the local crisis hotline. It's a wonderful hotline. It immediately locates your call and locates you to the nearest center.
That's absolutely right. I know in New York City, you can just dial 311 if you have a non-emergency, and they'll link you to health resources. And so we're going to double dip because you're also a pastor. So, when you're thinking about, we're talking about sin and all these other things, how can you activate your faith in these moments of crisis and help the individuals that are with you?
Activating faith is very important, because we know that faith and having religious, either private religious practices or public ones would be things like going to your faith communities, mosque or church, is very protective. And faith is protected for a number of reasons. One, it really helps people to have a sense of connectedness to other people. Two, really important concept called mattering. Mattering is not just people tolerating you, but people celebrating who you are.
Right.
If you make a difference, when you're not here, I notice that you're gone. What you think about and what you care about and how you feel is important to me. Not because of something you're doing for me, but just because. I love the saying in our church, we always say, I love you just because. You don't have to do anything for me. You never do anything for me. I love you just because. And in our church community, we talk about at the Beloved Community Church, that's the way God loves, and we are called to love the way God loves from a Christian theology. And so that's really important. Church, faith communities also sometimes have prohibitions against suicide, which are protective. The tricky part of that, though, is that if you focus too much on the prohibition and not enough on the connectedness and the mattering, you will also shut down communication. So there has to be a way for you to say that this is not optimal, that this is not something that a higher power would want you to do, but there's still no condemnation. There's this history of suicide as a sin really comes from a crisis in the Christian church in the 4th century. And people were engaging in mass suicide. And so Augustine, who was the bishop at that time, he was a Black bishop, he issued a series of edicts to prevent people from having mass suicide. And that edict at that time, church and state were not separated. So those also became legal premises under which suicide became a crime. And so, and we've sort of inherited that legacy from the early church without understanding there was a context in which that occurred, and then we no longer live in that context. So there is no scripture in the Hebrew Bible or in the Christian Bible that says suicide is a sin.
That's something I've learned today.
And, I said we're going to be
a theological issue, because when theology says that life is a gift from a deity, from the higher power, and we don't have a right to say it. That's true. That is in there, but it doesn't say something about suicide. And we know in the Hebrew text and in the Christian text, there are wars, right? And people kill people in the wars, and there's no condemnation for killing in those situations. So that's why you have to look at the text from a contextual perspective and understand, why did people say what they did? What was going on at the time? So having said that, do I think does that mean that that the higher power condones suicide? No. But is it unforgivable? No. We want you to make different choices. And part of the church's role can be to give you a lot of support and to provide you with, I always tell people, I'm going to loan you some of my faith while your tank is on E, because sometimes all of our faith gets low, including mine. Some things, life is happening and it's stressful and it's overwhelming, but the church can be that buffer for you to provide you with that support and that safety net while you're getting yourself the help you need. The church can also help link you to services.
Yeah, and I think and also an important part when speaking about the Black community, that the church has also always been a protective factor and a major part of our healing. When going through crisis, the church has always been something that the Black community has leaned upon. So it has a history of being a protective factor throughout our lives. So and even in the realm of mental health, we can consider it as a protective factor as well.
Good point. Yeah.
Oh, speaking of context and protective factors, let's look at the context of trauma and how trauma and cultural norms impact, decisions, that, may lead to ideation or planning. Can we talk about some of the trauma and cultural norms that impact that?
Sure. Well, we know that, I mean, there are several risk factors across different cultural groups: depression, anxiety, having a problem with substance abuse. We know that feeling hopeless, feeling helpless, lacking family support. But there are also some that are unique to communities of color, for example, experiencing racial discrimination and injustice. As we all know, that the recent focus on Black Lives Matters and the recent deaths by police from Mr. Floyd, Breonna Taylor, and several other people, this is in the forefront right now. Mm-hmm. So unfortunately, while those are traumatizing events, and we need to really understand, trauma does not have to be personally to experience for it to be traumatic. It can also be you witnessing trauma. And certainly with the advent of us all having cell phones now, we see the trauma live, in color, and in person. And in some cases, we see the trauma over and over again. Dr. Mack and I were talking when we were preparing for this program, and I was saying I saw a video on Facebook of someone put together all of the different police killings over the last couple of years and put them in one video. By the time I got to the third or fourth one, I had to stop. I was like, now I appreciate it's important for us to know what's going on in our community. That's traumatizing. And sometimes you need to turn that off, because if you have an underlying mental health challenge with depression or et cetera, that trauma really precipitates or exacerbates an episode you might be in, or can precipitate an episode. So traumatizing events are definitely a stressor. And sometimes people just kind of feel like, I've had enough. I really can't take anymore. I'm it. That's it. I'm out.
And it can add to the hopelessness to constantly be re-traumatized. So it adds to the hopelessness. Like, this is not going to get better. They're already feeling hopeless and feeling like they want an out. And so now they're seeing this over and over and over again, and it feels like nothing can get better. So then it adds to the hopelessness, which could, further, push them in that direction.
And the other problem is when you're depressed, your vision is very narrow, okay? And your lens is very narrow. So the example that Dr. Mack gave is such a good one, because you only see the negative. I was talking with some young people, and they were saying, when we're looking at the videos of Mr. Floyd and Ms. Taylor, and like, this happens over and over again. I said, that's true. But what's also true is look at the impact of Black Lives Matter in just the last few months. That we see people are legislating changes in how the police interact with the community. We see people taking down Confederate flags, see people taking down Confederate statues. We see schools, including my own school, reviewing the names of buildings. We see a dramatic shift in changing and in the psyche of the American people that I'm 63. I've never seen something this rapid before. Right. We saw the officers who murdered Mr. Floyd indicted within a week. So yes, it's true that this is traumatic, it's traumatizing, but it's also true, it's not the only thing that's happening. In addition to what that's happening, we also see really dramatic changes. We see people all over the world in large masses, in the context of a pandemic, go out and protest against the racial injustice against Black people. I've never seen that before. So it's not all doomsday, and it's really important. That's why we need to be connected. That when you're feeling depressed, someone else can say to you, "That's not the whole picture. I'm not denying that that's what you see and what you feel. That's not your entire reality." And one thing I like to share with people: this is a moment in time. This is not your eternity.
Yeah.
So the way you feel right now is bad and it's horrible, and we don't want to minimize that. But we also want you to realize that there is hope, that you're not always going to feel this way.
Right.
And you have to be patient with that, because when someone is feeling very depressed, it's going to be very hard for them to experience or feel what you're saying. So you have to keep saying to them and keep sharing with them and keep providing them that support and that hope and showing them the other side. Because as Dr. Molock said, their vision is very narrow. So they're going to want to keep going back to that hopelessness and that trauma and the thing that they see that supports how they're feeling.
Right.
So you have to be able to show them, and it's not easy. It's not easy. So you have to be patient and compassionate and just steadfast, as Dr. Molock was saying.
Right.
I think
it's a marathon. It's not a sprint. Okay.
Right.
Yeah.
Just as much as there's repeated exposure to trauma, there needs to be repeated exposure to hopefulness and happiness and joy and redirection and reframing. And I like how you bring up secondary and vicarious trauma, because sometimes we're like, people think, well, why are you upset? Why are you depressed? This didn't happen to you. This happens to someone else. But it really has an impact and can have an impact on how we see our lives, how we see our future, and most importantly, how we see the present moment. So I like how you make that an important distinction, that it doesn't always have to happen to you. It can happen to people around us. And
definitely. Yeah.
Yeah.
I know I'm a clinician, and I know Dr. Mack is a clinician, and you have a mental health background too, Brandon. I mean, I can't watch some of these films anymore. When I see Mr. Floyd, I cry every time, and I've seen it many, many times, but it's so upsetting. And I'm a mom, and so hearing him cry out for his mother really tears my heart apart. And so I think and I can see one of my children being in that same situation. And so I don't need it to happen to me for it to be traumatizing. I'm witnessing it, and I can have empathy for people who are being traumatized.
Yeah, absolutely.
And that empathy for others is just as important as empathy for self, and compassion for self. And I think that's how we can move through some of these challenges that we experience, especially now during COVID. Can we talk about some risk factors that we're experiencing during this time, during COVID, where we're at home? There's a great many of the population that are single and alone, which we can make a distinction between being alone and loneliness. Those are two different things. But there are people out there who don't have a support network. So can we talk about some of the risk factors for?
Sure. Well, I think one of the things we're really concerned about right now is that in some ways the COVID-19 combined with the highlighting of racial, and I want to stress, we're highlighting racial injustice. The racial injustice has always been there. We're just highlighting it right now. And it's on the 6 o'clock news every day right now. But for Black folks, it's not new. We're like, in some ways, we're almost kind of like, oh, we've been telling you this forever, but now you believe us because it's on a film. That's another topic. So I think we are worried because that combination in some ways makes for a perfect storm. So you have an increase in risk factors because of the exposure to traumatizing events. You have an increase in risk factors because people are isolated. So people are not able to get out and do their usual activities. People are facing financial instability right now. People may be having food insecurity right now. People are also sometimes sheltering in place with people that they may not have gotten along well with before. So we are very worried about people who may be in intimate partner violence situations, which means that you're stuck with this partner who may be verbally, emotionally, or physically violent towards you. We have people who may have untreated mental health problems. They're more isolated now, and they don't have access to their local mental health clinic. Or some people use the emergency room as their mental health clinic. They don't have access to that anymore because of COVID-19. So while you have this increase in risk factors, not to mention people have lost, right? In my own family, we've lost several family members to COVID-19 on my husband's side of the family. We have already done a few funerals. We've done 5 funerals or been participating in 5 funerals since COVID-19 started. And we're not able to engage in the typical rituals that we normally would to funeralize a person. And those rituals, the way we funeralize someone, the funeral is for the family. It's not for the person who's deceased. That funeral itself promotes healing. You come together as a family, you grieve together as a family. If you're in a traditional Black church, you have we don't even call it a funeral anymore. We call it a homegoing service. It's a celebration of a life well lived.
Right.
And so all of those rituals and all of those typical ways that we have of coping have been shortcut, curtailed, eliminated in some cases, while stresses are going way up. We know that connectedness is a really important support system. It's a really important protective factor If you live alone and you don't have that sense of connected with others, and you've lost your job and you're afraid of being evicted, and you don't have I call it your honey bunny, your significant other, and you don't have good access to friends, and maybe you're not calling family because you don't want them to worry about you,
Yeah.
then you see that perfect storm where you have all the risk factors are going up and the protective factors are going down. And so that's kind of a recipe for people who are vulnerable to start thinking about suicide.
And to just to add to that, when you work with individuals with depression and anxiety, part of the treatment is you prescribe connectedness. You prescribe, going out, getting exercise, meeting, hanging out with family, hanging out with friends, and they don't have the ability to do that in the same way. So even the treatment that they would be normally prescribed and is a part of their healing is curtailed. Even though they may even be going to their mental health therapist or seeing them on Zoom. But some of the things that would normally be protective or healing for them, they don't have access to. So as you were saying, that just makes it even more challenging for folks, and likely contributes to that increase of, in the suicide rates.
And we know that the calls to the suicide hotline have gone way up. In some jurisdictions, they're up by 1,000%.
Wow.
The challenge there is that Black folks typically don't call suicide hotlines.
There we go.
So those who are watching this, please, if you need help or you know a loved one, please use the hotline. There are people have asked me, people in my family don't speak English. They have interpreters there. They have people there who speak different languages. So you name your language, they can find someone there. Because remember, it's a national hotline. There are volunteers all over the country who answer these calls. So if you speak Portuguese, there's someone who can speak Portuguese. If you speak Mandarin, if you speak Korean, if you speak Vietnamese, if you speak Tongo, whatever you speak, they can find someone who speaks your language.
I think that's important to hear because, when there are people out there ready and willing to support you in your times of pain and processing, and it's startling to hear. I never really heard that statistic that, well, it makes sense. Black people don't call the hotlines. What is, in your opinion, around that? Why is that?
I think Black folks, and I should say men, don't call either. And so, ironically, some of the highest risk groups don't call. But I think some of that for Black folks is we don't air our dirty laundry. And also, I think when you're from a community that's marginalized, that's oppressed, where people already say negative things and have a negative connotation about your membership, your group membership, a lot of Black folks will say, you know what, I don't want to add to the stereotype that there's always something wrong with Black people. And so I'm not going to talk about feeling sad or blue. I'm not going to talk about feeling depressed. I'm not going to talk about panic attacks. I'm not going to talk about any of that because this is just another thing that negative that they could say about me because of my group membership. And there is some reality to that. But in the meantime, what you're doing is you're allowing some outside person's perception of you to dictate whether or not you get the care that you need. Mm-hmm. And so to me, those are two separate issues. If people have negative things to say about Black people, this will just be another negative thing they'll have to say about me because I'm still going to get the help that I need to get.
And Dr. Molock, I'm wondering, from your perspective and, your research and everything on this, do you think that our history in this country and the lack of trust that we have for, government or agencies and how even in the field of medicine, how we've been treated in this country also plays a role in why we may not call some of the hotlines as well?
Oh, definitely. I think all of us forget sometimes, I know I do, that many of the organizations who fund the hotlines and fund the research that we do, which is important, are government agencies. I think those of us who do this, we just think it's SAMHSA, we just think it's the agency. We forget that to the larger public, it's the government, which is true, it is. It's not, I'm not saying it isn't. But so there's a lot of hesitancy about what do they do with this information.
Yes.
If you say to people like this, calls are anonymous. So unless you are in a life-threatening situation, no one's going to look you up. No one's going to take down your information, your personal or identifying information. But people don't feel comfortable with that and feel like, is this going to be used against me later on? And Dr. Mack is right. There have been abuses in the past. We know the Tuskegee experiment. There were women, Black women, who were sterilized involuntarily in the South in the 60s and 70s. And so there's unfortunately a long history of abuse. When people say to me, well, that doesn't happen anymore, you just need one or two exemplars or stories that are well known, and then they take on a life of their own. I can tell a quick story. My dad, after my mom died, was having some neurological symptoms. And so I was saying to him, you know, Black people, we tend to somatize it. We tend to have our mental health issues in our bodies. That's the way we express it. And I said, maybe you want to talk to somebody, you know, a psychologist or a counselor, to talk about your grief because my mom died unexpectedly. And he laughed and said, no, I don't need that. I don't do that. And so I said, well, you're talking about a psychologist, right? He said, yeah, but I don't really need that. And so I asked him, well, why do you feel like that? So he told me when he was a little boy and growing up in East Baltimore, their perception of psychiatric care was somebody came in a white truck and they took your family member out in a straitjacket. And in those days, they had prefrontal lobe lobotomies, and the person came back like a zombie. So then I realized that's why my father would never go see anyone, even though he knows I'm a psychologist, even though he knows that I do treatment in a different way. He intellectually understands that, but his visceral emotional response to therapy is people take you away and bring you back as a zombie. That's something he learned as a child, and that image is never going to leave him.
I think that's a great story and a very good way to illustrate how we can't always ignore the historical context of any situation and why these myths persist and why behaviors persist. And so we must be empathetic, you know, in moving people towards helping, supporting people towards healing, because there are things, trauma that has happened in people's lives that impact their present experiences and behavior. Let's move and talk about social justice movement and how that can be a protective factor against suicide.
What the wonderful thing about the protest movements is that, one, it's a way for people to express how they feel. It's very cathartic. It's unfortunate that it's occurring in the context of COVID-19 because it has curtailed some people's ability to go out and be protest, including mine. I'm in several risk groups. So this is the first time I have personally not engaged in the protest movement. Our church is normally very actively involved in that. And my young adult children, who also tend to be very active in social justice movements, did not protest in order to keep their father and I safe from being exposed to the COVID-19. But one of the things I share with my children, though, there are other ways that you can help. You can make donations. You can do writing campaigns. You can, I'm always boycotting somebody. So you can boycott stores. It's a family joke. Mommy, who are you boycotting right now? Because I boycott people a lot. But I really feel like economic pushback is really important. You can do that. So the protests in of themselves can be very cathartic. You can also see the protests bring on awareness to the problem, but they also, because people have more awareness and more solidarity and more unity around a problem, then you can also use that as leverage to affect policy change. And that's one of the beautiful things I'm seeing right now in the movement now is I'm seeing policy change. I'm seeing people try to be really creative with what should the relationship between the police officers from law enforcement and the community be, and let's create that relationship. And so we don't have to, when people hear defund the police, they don't necessarily mean you're abolishing the police department. It means that you are reallocating how the funds are used. And so, for example, we have more community policing. I was just reading a story in the Post today about an officer in Huntsville, Alabama. Well, there's something called CIT training where police officers and law enforcement are trained in crisis intervention. And so that's the good news. Many officers around the country are trained with that. But the issue is, do you use it? Right. So are there ways that we can incentivize officers to use that training? And if you read the article, I'm going to encourage you all to read it because the officer is real honest. During calls, he sometimes weighs into thinking it's not a mental health challenge call, and he treats it as another kind of call and he was wrong. Okay. Fortunately, there was no fatality involved there. Another thing that he brought up in the article was he feels that they should have mental health specialists assigned to units to go do these calls because they only have 16 hours of training on that. They have a lot more training on the, for example, the use of force, how to disarm someone. So, and I think that's a valid point. So are there different ways we can fund law enforcement with bringing in expertise with helping people diffuse these mental health calls in ways where we have better outcomes than we do now?
So we're going to move into, some of the things that are happening in the media, because sometimes what's happening in real life we can really identify with and express and see ourselves through those people and events. And we're talking about risk factors and helping and supporting. And sometimes, no matter what you want to provide to someone who needs help, it's really a choice that they have to make themselves. And we can look at, we had a conversation before about, Kanye West, and maybe some of his behavior. And really, how can we help people that we notice risk factors, we notice things are happening in their lives, but we don't want to, we can't rescue them, we can't make them do anything. How do we support people in our lives that we want to help, but kind of feel helpless and hopeless?
Yeah, I think the Kanye West situation is sort of a classic example. It's unfortunately not atypical for someone who has a chronic mental health challenge, and I think he's openly acknowledged his bipolar disorder. His family has that unfortunately it is a lifelong struggle, and so there are times when people stay on their meds and stay in treatment, and then sometimes they don't. Bipolar disorder is a little tricky because sometimes when people are having a manic episode where their mood is really elevated and they feel euphoric and they feel special and feel that they have this tireless energy, and then sometimes they can feel that they're most creative. They don't want to lose those feelings. And so they're not really motivated to go into treatment or to be on the medication during those periods of times because they feel great. They may not be acting rationally. And as we can see some of the clips from Kanye West's behavior, he doesn't seem to be necessarily acting rationally. But it's a struggle for the family too. I think some people are criticizing the family, and I think that's unfair because one, we have to remember we're seeing snippets of his life. We have no idea what's going on behind closed doors. We have no idea how long this episode's been going on. We have no idea what they tried to do to get him to get into treatment or to change. We don't know for a fact he's not in treatment. He may need to change something. And that happens sometimes too. Sometimes you're on your medications, you are taking them, and they stop working, your body acclimates to whether you may have to switch or tweak your dosage. And so that sometimes happens too. But you're right, you have to participate in your own treatment. So someone can't even if you're involuntarily hospitalized, which is very hard to do.
Yes.
Someone can't make you engage in treatment if you don't want to do it. So really part of what I think will help this is if we continue to destigmatize it. I think it's better. I think the fact that we're having this show today which is wonderful. So thank you again for inviting me. All of this, when we get the information out and we're talking about it, helps to destigmatize it. But unfortunately, we also need to socialize, particularly in the Black community, our children, men and women, boys and girls, that it's okay to get help. Because particularly men are less likely to access services because we socialize men to be very individualistic and to be strong and solve problems on your own. And if you go seek help, it's a sign of weakness. So those messages, those scripts that we have for men are toxic. And they don't just lead to mental health challenges, they lead to other kinds of health challenges. It's not a coincidence that men tend to have shorter lifespans than women. Women are more likely to engage in and use their emotions. So it's, it does take a village. It takes lots of people, as Dr. Mack said earlier, repeating the message, being supportive, letting the person know that you're going to hang in there with them until they can get the help that they need is really important. They're going to have to be there for him afterwards. And it sounds like, I don't know, his family well. Obviously, I don't follow the Kardashians. I'm probably the only person in America who doesn't. I don't. But it sounds like they're supportive and they're trying to get him some help. But they're going to have to hang in there until he wants to get some help. I think some people have asked why don't they hospitalize him? It's hard to hospitalize someone against their will. They have to be in imminent danger to self or others. Because someone is behaving irrationally is not the same thing as being dangerous. You have to be worried that in the next 48, 72 hours, you think he's going to hurt himself or hurt someone else. Those two things, or if he's unable to take care of his daily needs, that's another criteria.
Yeah.
He looks fine. He's dressed. He's not disheveled. He's eating. He's sheltering somewhere. But even if you're homeless, and unfortunately, a lot of people who are homeless are mental health challenges. If you're walking up and down the street and cursing, if you're not trying to hit anybody, you're not trying to assault anybody, and you're not harming yourself, that's not the criteria for an involuntary hospitalization.
Yeah. And even if the person, a person might seem suicidal to you, you can suggest, and they can go into the hospital, and then they'll get to the hospital and there'll be a risk assessment done and they'll send them home, where that person may have been in harm's way at the time, but they can go to the hospital and they'll present, or they'll answer the questions in the right way, or there may not be the emergency room was packed and they just didn't have the time, or the person was not very well trained in doing suicide assessments, and then that person could come back home.
Right, I've had that happen.
That just, adds on to what Dr. Molock was saying about, what was that? That just adds to what Dr. Molock was saying about the difficulty that you have with involuntarily hospitalizing someone, even though you may feel like that may be the safest place for them. They may not necessarily end up being in that situation, in that hospital situation.
And we have to be empathic. I think sometimes other people, family members, and definitely clinicians are a little insensitive to, no one wants to be involuntarily hospitalized. I have very few clients who say, I can't wait to get into the hospital. So they don't want to go anyway. And then to go against your will is humiliating. It feels, no one likes to lose their personal freedom. And so I think the issue about hospitalizing or not hospitalizing, it's the choice you want to make your last choice. You want to hopefully be able to treat someone, and majority of people can be treated on an outpatient basis. So you want to make sure you can have people have access to treatment, and it still takes a village. The treatment by itself is not a magic wand either. It takes a village. It takes the treatment, in some cases medication, supportive environment, making sure that people are engaging in the things that they need to do coping-wise so that they can get better. All of that stuff together works together so people can have productive lives.
I think it's important to, that's great highlighting that it takes multiple, forms of support and really repetition. Sometimes we think it's a magic wand. You do one thing, you disappear, everything's fine.
You're all good. Yeah, no.
It really requires work to change the conditions and the behaviors that have sometimes manifested over long periods of time. So it's really going to require not just a phone call or one time you support someone, but it really requires a commitment. And it's not impossible, because we know we can work and do things, but it's not easy. And I think people shouldn't expect, sometimes that we get these feelings of, we can take medication and that's it, or we can go to therapy and that's done, or it's a challenge, and it may be lifelong.
The treatment of choice for depression is a combination of for moderate to severe depression, is a combination of medication and therapy. The medication is going to stabilize your mood. So there's a myth. People call it my happy pill. It's not going to make you happy. It's going to stabilize your mood. So you make yourself happy. You have to do that. But then you still have the same maladaptive coping skills. So that's why you need the therapy to help you to adapt different coping skills. In order for the coping skills to work, you have to practice them. I do a stress management group for my church on Tuesday nights. And we do meditations every Tuesday. That's what we start with, and we often end with that. And I share with them, we can teach you to be relaxed in about 90 seconds. Correct me if I'm wrong, Dr. Mack. It's quick. But in order for it to work that way, you have to practice every day. Okay? Not all day, every day. It's like 20 minutes, but because you have to be able to remove yourself from the stressor mentally shut everything else down, focus, which is very hard when you're in a stressful situation, the focusing, and then do the deep breathing, and then relax. All those scripts you have going on in your head about you're a bad person, this is stupid, oh my God, I'm just use plane, for example, the plane's gonna crash, all of that, we can teach you techniques to turn that off. But it won't work if you don't practice it.
Yeah.
It's important to have that memory of, reconditioning not only your thoughts, but your behavior.
Right.
If it's not practice, then it's not going to make
Not going to work.
Impact.
If I will say it didn't work, I'm like, well, how often are you practicing? Well, it's been a couple of weeks. Like, no.
Yeah.
It's like brushing your teeth. Every day you do this.
Right.
And to add on to that, I think it's important to also stress that if you do get a therapist and that therapist is not the right fit for you, you can find another therapist. You do not have to continue with that therapist. I think that also contributes to individuals' inability to get better because they'll try it. Oh, I didn't like this person. I didn't connect with this person. Or they'll go for, 4 sessions. It didn't work, but that's not how it works. This is, as we've been saying, this is a marathon. This is not, a sprint. So if you find a therapist and it's not the right fit, get another one. If you go to you buy a dress and it doesn't fit, you're going to take it back and you're going to buy it. Right? So,
we were talking about if you had a plumber, if you had a leak in your house, you wouldn't let your house flood, right? You'd get another plumber. So
you're not gonna be like, oh, we're going to swim around here for a while.
Right. No, that's not what's going to happen. And, I like to always stress that. Thank you, Dr. Mack, for bringing it up. But therapy is a collaborative. It's a partnership. And if you don't find a therapist that honors where you are and can work with you and moving you forward, then you have every right to switch and find someone else. It's not the end of that story. And, Dr. Molock, you are a reverend and a pastor, or you're a pastor and a psychologist. So you have the competency to bring many aspects to therapeutic process. And it's really important, right, to find someone who is competent in who you are and have multicultural competency.
Right, definitely.
Absolutely.
Specializing, doing the work that you need and helping you move forward.
Yeah, if you have a therapist and the therapist does not get you for cultural reasons, they don't, and the people struggle with this because they'll say, well, I don't know anything about that culture. Okay, but when you don't know things about other things, what do? You look it up, right? You go to classes or you take seminars or whatever, and you become more knowledgeable in that. And so even before I was a pastor, I would talk about spirituality in the sessions because spirituality was a protective factor. And it would seem to me to be strange not to talk about it. Was I praying in the sessions? No. Was I proselytizing or evangelizing? No. And I don't do that now. My goal is not to convert anybody. My goal is to be a therapist. And so what I'm doing in that therapeutic moment is I'm trying to understand with you, how do you use your spirituality to be helpful to you? Sometimes it's not helpful. How is it a hindrance to you? And then let's work on how we can, it's just one tool of several we have to help you to have what I call thriving. We don't want you to just survive, but to thrive. And so this is just one of the tools we use in our arsenal to help you have a more productive and a happier and you have optimal living. We don't want you to just make it. We want you to have optimal living.
We want you to live fully.
Live fully, right? MECCA wants you to live fully. And sometimes you're right, Dr. Molock. It's just a tool, and sometimes your therapist, unfortunately, may not have all the tools in the toolbox to help you. And at that point, it's time for a referral. It's time to find someone else who can help you. It's actually their duty to assist you in finding someone who is competent to assist you. But it's not. It's not the end for you. You should continue and do the work to find something that works for you, and you have every right to do so.
And also for the therapists out there, do your homework. I mean, we have sometimes work with people who are from a different faith background than my own. I don't just automatically refer them out. I actually look up their faith tradition. Guess what? I ask them questions. It's like, wow, you celebrate Ramadan. Can you tell me more about that? It was just like I would ask questions about other things. I just ask questions. Clients love it when you ask questions because then I'm not going to pretend like I have more knowledge than I do. I don't. I don't have to be an expert at every single thing or every single faith or every single culture, but I have to be curious and be willing to go on this journey with you, that we can learn from each other as well.
I think that's
Absolutely.
important.
Very important.
That's very important to
No,
say.
that's absolutely very important, because you're showing them that you are genuinely concerned and that you want to learn about their culture. But if you pretend that you know and then you're saying something wrong, you're going to offend them, and then that's going to build an even bigger bridge. It's going to be a bigger wall for somebody who may already be a little have a little trepidation about coming to a therapist, and then you do this. Oh, I'm not coming back here. So that is really important, to ask the questions, let it be known that, you're here to learn and that we're here to collaborate. We're here to work together.
Right.
I'm not the master of your health. I'm here to support you on your journey to better mental health.
Right.
So we have 5 minutes left.
Wow.
Time
We
to
were
reply.
talking, right? So how can you see your family member, you see someone, you notice some changes in behavior, you notice some, risk factors, or you may be on the edge right now, you're watching this, you're stressed out, you're in distress. What do? How can you move towards healing?
First of all, we want to share with you that you're not alone, and that there's no shame or humiliation in having mental health challenges. It's estimated that about 1 in 5 people will have a mental health challenge in their lifetime. So you're definitely not alone. We ask that you talk to someone. If you don't feel comfortable initially going to a therapist, talk to a friend or a family member. If you are that friend or family member, please do not be judgmental. Don't be condescending. Don't say, well, that's silly, or dismissive of it. You'll get over that. But really what we call join with that person, be in the moment with that person, be present. Don't text and pick up your phone while the person's talking to you. I've seen people do that. But let that person know, you in this moment, you have my undivided attention and I'm here for you. Listen to what the person is saying and gently suggest to them that maybe you need to see a professional. I'm going to still be here for you, but this is beyond my scope of expertise. This is not what I do. And one of the things I share a lot, particularly because I see children and teens, is remember, for your therapist does this all the time. Your child or your loved one is not the first depressed person or suicidal person they've ever seen. It's very overwhelming for you, but it's not overwhelming for us. This is what we do. So don't assume that because you're thinking of suicide that we're automatically going to make you go to the hospital. Most people can be treated successfully and not go to the hospital. In fact, our goal is to not have you go to the hospital. That's the goal. One of the markers I use for some of my clients is, can we keep you out of the emergency room and the hospital? That's a goal we have. So let's not have to do that. We have to, we will, but that's our goal, is not to have that happen. So then if you don't feel comfortable and you're in a crisis, please use the number that's under the scrolling up at the bottom of the screen. Call the National Suicide Prevention Hotline, Helpline. It's very important to do that. To remember that this is not your eternity, this is time, that there is lots of good help available. There are effective therapy techniques that you can have. And for all of us to remember, we need to be the village that helps us support each other. We are the ones we are looking for and waiting for. You can be that change agent.
Yeah, absolutely. I 100% agree with everything Dr. Molock said. It's just really important to be that support for that individual, and just giving them their undivided, unconditional love and support and ear, and not being judgmental. That's sometimes you don't even really have to say anything.
Just be present.
Just be. Let them speak. Let them talk. Let them say everything they need to say, even if you're just sitting there nodding your head, because sometimes they just need to be affirmed. They just need someone to affirm them. They just need someone to say, I hear you. I see you. And
then you don't have to fix the problem, because sometimes the problem is too big to be fixed in 1 10-minute session. It's like, but what I'm promising is I'm going to be here for you as we work through this. It may not be today, it may not be next month, but I'm going to be here with you through this, through thick and through thin. I'm going to be your ride or die.
I like to say I like to support, not rescue. I don't have a cape, but I can sit with you.
Yeah.
Dr. Mack, can you give us resources if they want to reach the MECCA Group for services?
Absolutely. The MECCA Group, we do have, wonderful clinicians there that can help with anybody who's experienced any of these emotional challenges, depression, anxiety, some of the things that we've talked about. We can be reached at 202-529-3117. You can visit our website at www.themeccagrouplllc.com. You can follow us on Facebook. Some of you are right now. And you can also find us on Instagram, and you can reach out to us in any of these ways, and we are happy to help you get connected with someone. And even if it's not at MECCA, we take, MECCA makes it a very valiant effort to get individuals connected that want to be connected and helped. We won't just say, oh, we can't help you and hang the phone up. We're going to really do our best to try to connect you with someone.
Well,
and I can speak for her because I helped train her.
She did a great job. Uh-oh, is Brandon stuck?
I know. Uh-oh.
Brandon, you stuck. We're going to have to sign out without Brandon.
Okay.
Oh, he's back. Wait, I think he's coming back.
Okay.
I think we're
what happens when you're live.
Well, I'm glad it happened like that at the end of the internet.
What happens when you're live?
Yes, internet was like, it's time to go. Well, thank you so much for joining us today and giving these great resources. Please share, comment, and share this with someone who you hope to support, who you think needs support, or just people in general who you think might want to see this. We'll see you, I guess, in 2 weeks.
Yeah.
All right. Bye, everybody.
Yeah, and thanks for inviting me again.
Thanks for coming. Bye-bye.
Bye-bye.